and keeps things organized. The interesting thing is there's this core group is there's been some folks who've come into and sort of exited from HealthBlawg Review over the last 10 years, which is certainly to be expected. And our latest host, the gentleman who hosted the latest edition, is Charles Gaba of the famed ACAsignups.com blog, which is probably one of the most read blogs out there. So it's certainly a privilege to have him join us. And I think this morning or this afternoon, depending on where you are, we'll be chatting about a couple of posts specifically from his most recent edition. And I think the ones that you contributed, David, as well as Louise's on balance billing are particularly appropriate these days.
Well, great. So I'm going to drop a link to that edition in the sidebar here. So folks who are watching either live or at some point in the future can follow along at home and take a look at the posts that we're talking about here today. So, Joe, did you want to kick this off with a discussion of one or more of the posts that we're talking about?
Sure. And actually, I think there's two posts are the one you put up about California's efforts to try to get the state's arms around the whole narrow network issue, along with Louise's on balance billing and I've got it up here on my other screen, at in-network hospitals are really germane. As folks who have signed up for exchanges or are with employer plans that have changed dramatically over the last couple of years, as health insurers and health plans have really sought to shrink down their networks to achieve better prices, quite frankly, and also to gain more control over utilization. What we're seeing is confusion on the part of patients, myself included, in terms of you go into a hospital, you try to see a physician, and then you find out that they were in network and they're no longer in network. And we're in the process of trying to find a physician for a family member who's got a chronic medical condition and fighting through that whole process. And it turns out that the health plan that we're part of here in upstate New York doesn't have a specialist in this area within 100 miles. So these are more than growing pains. And I would emphasize the pain part of the whole health reform issue. And I think one of the ones that's illustrated in Louise's post is the whole issue of balance billing. If you go to an in-network hospital, you would reasonably expect that you're not going to get an out-of-network provider because you went to an in-network hospital. You got your care from an in-network physician, probably an in-network anesthesiologist. And Louise notes that in an experience her family had, her husband actually had to deal with some out-of-network bills because of a non-network durable medical equipment provider and potentially another type of provider. So these are the things that kind of make patients crazy, because doctors and hospitals, insurance companies are supposed to be working together a lot better. And clearly, we have a long way to go in that regard, whether it's having a narrow network that actually includes the providers that you need, in our case, a pulmonologist for chronic lung condition, or in Louise's case, and probably everybody's, in terms of trying to make sure that if you do what you're supposed to do and go to an in-network provider, how do you not get dinged for some significant charge when you thought you were doing the right thing? I think this is a place that health plans really need to do a much better job of addressing this issue. And I noticed, David, you discussed at some length the regulation and legislation surrounding narrow networks and how we can better sort of control that. I think it's sort of incumbent upon the health plans themselves to actually take the initiative in doing that, because they're the ones who suffer when we, the consumers, the patients, get cranky with them. And that's probably nothing that they aren't used to, but ideally they would sort of take that as an opportunity to demonstrate better customer service. So, Louise, I really enjoyed your post. It's certainly something I think a lot of us have experienced. Do you see anything like that changing in terms of the balance billing? I know you were talking about Florida in specific. Do you think this is a trend that's going to affect other states?
Well, I think that it's going to become more and more of an issue because of the narrow network specifically. Uh-huh. And so I think this has always been an issue. And in my recent article, I'm linking back to, Jay's knee surgery was in 2008. This is by no means new as a result of the ACA, but narrow networks are one of the ways that health insurance carriers can, curtail costs at this point, because they've lost a lot of the other ability to do so. And so it makes sense that we maybe are seeing this more than we used to. Uh-huh. And I think sort of the point I was trying to make in my article was there is legislation, and it's not just Florida. I mean, there's the model NAIC legislation that's, that would apply everywhere. And other states have certainly introduced legislation. New York has actually passed legislation, is my understanding. But so much of this legislation still sort of puts the onus on the patient to figure out, they'll say, okay, we're going to do this law that's going to make it so that the hospital has to tell you that you need to check with every provider you're going to see, and that some of them might not be in network. Well,
right. Thanks a lot. That's really helpful.
Yeah, exactly. And I mean, I think in the case of, like, for myself and Jay, when he had knee surgery, we had been in the health insurance industry already for years at that point. We knew to sit down with the front desk people and say, okay, we know the surgeon is in network. We know the facility's in network, but what about the anesthesiologist? What about the radiologist who's going to be looking at the MRIs while they're doing this? And they said, yep, everybody's in network. You're good to go. Well, we didn't think to ask about durable medical equipment. And when he woke up from surgery, the equipment was already on him and sitting next to his bed. And so I feel like a lot of people might not even know that they need to ask about the anesthesiologist. They might assume that if they go to a hospital and have surgery, that the people working in the hospital, I think it's not necessarily understood by the general public that hospitals, the doctors and providers working in a hospital aren't necessarily employed by that hospital. They're under contract,
right?
But they have privileges at that hospital. Doesn't mean that they are an employee of that hospital. And so I feel like there's just still way too much responsibility for the patient to sort of figure it all out and make sure all their I's are dotted and their T's are crossed, when it could be, I feel like it's something you should leave to the professionals. The patients are not professionals when it comes to dealing with this sort of stuff, whereas the hospital and the insurance company, they are the professionals. And obviously there's providers who don't want this to be the case. If you're a radiologist or an anesthesiologist and you work behind the scenes and you can make a lot more money not signing up with insurance networks, then it is obviously in your best interest maybe to do so. And then on the flip side of that, you also have the fact that some of these insurance, with the narrow networks, some of the carriers are purposely limiting the scope of their network. And so the providers might not have the option to join. They might say, we've already got X number of radiologists in our network. We're not taking anybody else. So it's really it's not that you can really put the blame in any one place. It just needs to be everyone working together. But the Florida legislation was sort of rolled out as isn't this great? We're taking the patient out of the middle. But if you really read the legislation, they're not taking the patient out of the middle. They're just informing the patient better about how much they're in the middle.
Right. And who has the wherewithal very few people have the wherewithal to deal with all of that. And frankly, don't have the tools to deal with all of that, or the ability, as Joe's example demonstrates. In some cases, it's a geographic access problem. In your example, it's the case of waking up and something has happened and you never even thought to ask about it, even if you thought to ask about everything else. And that's a huge problem. So the legislation that's currently percolating through doesn't really solve the problem. Aside from single payer, et cetera, what are the potential intermediate solutions that you see to a problem like this?
I feel like I really do think this is becoming more of in the mainstream media, there's definitely become more public awareness of this, or at least I'm seeing it a lot more than I was, say, 10 years ago. So I feel like there's going to be sort of more of a public outcry for this to be fixed. And I don't know. I mean, there are some, obviously, like the Kaiser model, if you go to a Kaiser facility, you're good to go because everybody there is employed with Kaiser. That is one extreme where obviously, isn't going to appeal to every carrier or every person who wants to get insured. I mean, people do like the PPO model. But tiered networks add another element of excitement to the whole thing in terms of, if you go to a top tier provider and then all of a sudden you have lower cost sharing. If you go to a, second tier provider, you just have the normal cost sharing. I really do think that there's going to need to be more, maybe just legislation introduced on a state by state basis, but it needs to be people sort of raising a ruckus about the problems that they're seeing, and the more that gets on the radar of the general public, the more people call for changes and improvements.
Yeah,
right.
I mean, Frank, here just for
sure.
a second, what really strikes me about this is, we're sort of the health nerds, and we deal with this stuff 24/7, and we can't figure this stuff out on an ongoing basis. And it's if you, Louise, and your husband don't think to ask about durable medical equipment, most citizens out there can't even spell durable medical equipment, and they shouldn't, because they don't deal with the healthcare system on an ongoing basis like we do. I'm sort of reminded of what happened 30 years ago when I started my business career, and I had to buy a computer for the university where I was working. And I remember on a government project, and it was a green screen, and I had to learn, programming and BASIC and all this other stuff. And I kept thinking, these computers are never going to go anywhere because they're such a pain in the ass to use. Who's going to figure this / and you work for an hour and a half and you go back and you find that you used a semicolon instead of a colon, and the whole thing blows up on you. So what happened? Well, here we are talking on Macs or Windows that are trying to act like Macs. And it's greatly simplified the use of technology and enabled us to do things like this for zero cost. And I'm wondering when the medical insurance, health plan industry is going to haul its collective head out of its nether regions and simplify this whole process for us. I think about going to Kaiser. I wish the heck we had a Kaiser up here in upstate New York. I'd join in a heartbeat, because I wouldn't have to deal with balanced billing. I wouldn't have to deal with these out-of-network providers. I wouldn't have to deal with all of this nonsense. And it would be simple. And healthcare should be simple. It just strikes me that there's a huge opportunity here for the healthcare industry, largely defined, to sort of get in front of this and be consumer friendly. Because right now, they want to publish prices. Well, who the hell knows what a CPT code is, or an ICD-10 or anything else? And how do you track that back to where you are, and what happens when this changes? And then who knows if they're in network? They were in network, but now they're not in network, and something happened between the time you checked it, et cetera. That shouldn't be the patient's responsibility. That should be the responsibility of the health plan. Just like it should be the responsibility of the computer maker to make it easy to use. It should be the responsibility of the healthcare delivery system to make it easy to use as well. And I think unless we do that, we're going to continue to have pretty crappy healthcare in this country for the vast majority of folks.
Yeah, it's a problem. It's interesting. There's a California law on the books that is requiring health plans to publish updated network, participating provider directories and update them on a weekly basis. They were previously required, I believe, under the ACA to update them on a monthly basis. Well, these directories are so useless and so out of date. But I think the problem is that I would think that the plans would have this kind of information, or ought to have this kind of information in their contracted provider databases. And if they're not able to do this accurately on a monthly basis, I'm not confident that they'll be able to do it on a weekly basis. And if the plan doesn't know who's in network and who's out of network, we really have a problem. So sort of a broad question. And then, that raises also for me the question of, what is the utility of a narrow network? As you mentioned in the post that I wrote, Joe, I raised the issue of narrow networks as sort of a no-brainer and something we should be open to. And certainly it works in a closed system like the Kaiser system. But in a broader system, if we have a narrow network, you run into the problems that you both have experienced firsthand. And for all that we may like the idea of narrow networks in terms of their utility from a quality control and cost control perspective, it creates an access problem unless there can be some way of controlling for that. And, sitting here today, I'm not sure we can solve that problem.
Part of the problem I think you have with that is geographical differences. If you're in New York City, you're probably going to have no problem at all getting enough providers for every specialty you could imagine within, a very small geographical area. Whereas you're in Wyoming or Alaska, and again, you take a look at the insurance rates in places like Wyoming and Alaska, and they're through the roof, because in order to get even any specialists. You might have to go 200 miles no matter what, and that might be the only specialist there is. It's not that the insurance carrier is limiting them, there just really aren't any. So I think one of the problems we face, especially when you look at this on a national level, is just the vast diversity we have in this country in terms of, how many providers are in any given area. And if you're going to create reform that benefits everybody, it has to be a very adjustable system to account for that.
Right. As Joe mentioned before, talking about the wonders of technology, in some respects, technology will help us solve that with telemedicine and other technological advances in delivery of healthcare services. But that's, of course, a work in progress, and I'm sure we'll have much to say on that in the future. Joe, if I can, in the time that we have, I'd like to turn to your post that was in this week's edition of HealthWonk Review regarding opioid abuse and the move to deal with this on a state-by-state level. You cited legislation in my home state of Massachusetts, and I wonder if you could talk about your perspective on this issue.
Yeah, it's very timely. Earlier this week, I was at the same conference President Obama was. He actually came down to the RX and heroin abuse summit down in Atlanta. I've been fortunate enough to attend for the last 5 years. And my talk was obviously not quite as well covered as President Obama's, but but this is one way we can get that message out there. But I was focusing on it from the workers' compensation end of things, where we have become the addiction creation industry. About a third of drug spend in workers' comp right now is for narcotics and almost all opioids. And this is for an industry that has no breakthrough cancer pain, essentially. So how have we as a society evolved so that people who can present in a doctor's office with non-skeletal back pain, just soft tissue industry, and get Vicodin or Percocet or something even stronger? It's appalling. As I was talking at the conference, there's a ticker set up behind you. So it would be up there, and it counts the number of people who've died so far this year due to opioid abuse. And we're talking 28,000 people in 2014, 28,000 people. And it all starts with a doctor writing a script. Another statistic that was just awful is 75% of the people who use heroin started on prescription opioids. So again, a doctor had to write a script for that. That's the only way you can get those. Now, they might have been diverted or abused or what have you, but a doctor wrote a script for that. So I think the recent moves by CDC to come up with guidelines, despite some of the caterwauling from the pain advocates who are backed by a lot of large pharmaceutical companies in some instances, there's nothing from the CDC or DEA or FDA restricting access for people who have long-term chronic pain or have cancer pain, et cetera. It's all about the initial scripts. And as you look at the use of opioids, it also varies dramatically from state to state. So obviously, the hills of Eastern Kentucky, where Operation Unite, who runs the conference, came from, it's a huge problem. There's one town in southeastern Indiana where a huge percentage of the population there now has HIV because of needle sharing. And there's all these sort of related sort of micro health disasters in different areas due to prescription drugs as a trigger. So what we saw in Massachusetts is legislation essentially limiting the initial prescription to 7 days. In some states, they're looking at 3. Other states, my former home state of Connecticut was also looking to limit at 7 days. Other jurisdictions are as well. And kudos to Charlie Baker, the governor of Massachusetts, for really pushing on that hard. I guess as one who's sort of been fighting this fight for the last 7 or 8 years, it's a little, I don't want to be upset that they're finally getting involved. So better now than 2 years from now. On the other hand, gosh, it would have been nice if they'd been there back when deaths were only 14,000 and hadn't doubled to this rate. So I think what we're going to see is a lot more action in different states looking at opioids and prescription drug abuse. There's just one final comment on that, and this is really troubling. If you look at the how opioid abuse is being dealt with and how prescription drug abuse is being dealt with today. It's treatment and it's understanding and it's a disease and all this other great stuff, which is absolutely true and totally valid and consistent with science. Back when it was a crack situation or injectable heroin in the inner cities, it was, let's throw them in jail. These are drug addicts. They don't have enough willpower. They're not being productive people, and they're robbing other folks. And this, quite frankly, smacks of racism at best. And I think it's encouraging that we're looking at drug abuse as a treatment issue, because it's absolutely a disease. Addiction is. On the other hand, I think it would really be helpful if we sort of looked back at all these lives we as a society have really damaged by criminalizing this type of medical condition, and see what we can do to somehow right that wrong.
Yeah, heavy stuff, powerful stuff, Joe. It really is. Yeah, I can imagine. I saw this incredible post on NPR. I just dropped a link in the sidebar to an interview with Dan Baum, who has an article in the current issue of Harper's Magazine, and he wrote a book about drug policy and the question of whether we should simply legalize drugs, as some places in the world have done. I think Portugal comes to mind, and you sort of remove a number of different kinds of problems from the equation. We could debate whether that's a good idea. The point I wanted to make here is about 20 years ago, this guy, Dan Baum, tracked down John Ehrlichman, who had been Nixon's drug policy advisor when Nixon declared the war on drugs. And he was starting a whole sort of wonky discussion of the policies about the war on drugs. And he said, Ehrlichman stopped him and said, "Can we cut the BS? The war on drugs was about Nixon and Nixon's enemies. His enemies included black people and hippies. And the war on drugs was their way of associating heroin with black people and marijuana with hippies. We could put police into those communities and gather information, lock people up, get them on the evening news." Just so cynical, is unbelievable. I guess maybe to be expected from the Nixon administration, but a little bit shocking. But we're dealing with the fallout. A lot of what you're describing, Joe, is sort of the fallout of that sort of war on drugs attitude, and sort of what we're left with. And that, combined with the marketing efforts from pharma, I dropped another link in the sidebar to Roy Pose's recent post on this. It wasn't anthologized in the last edition of HealthBlawg Review. It's more recent, so I included the link there. And he just goes through some very interesting information about the manufacturer of OxyContin and the way that drug has been marketed over the years.
I would suggest that nobody read it today, because it'll ruin your weekend. The history of Purdue is a checkered at best. So just a quick question, Louise. Obviously, in terms of doing different things from a policy perspective, Colorado has been quite innovative. At least that's one perspective. Is there much backlash or pushback in Colorado from what you've seen with the legalization, and it's more than decriminalization of marijuana? Do you see this growing to other states?
Oh, I absolutely see it growing to other states. I think before, Colorado we legalized medical marijuana several years earlier. So people were already used to seeing the dispensaries, here and there. And they would all have a medical cross on them to show that they were a medical establishment. But then leading up to I can't remember if it's been 2 years now or 3 years that since they, it's legal for everybody. But before that, we had, all sorts of people saying, oh, this is going to be the downfall of our society. We're going to have all the, high school kids, every one of them is going to be high in class. And it was just, they were there was a lot of fear mongering, but then there was a lot of sort of reality, people on the other side saying, well, no, high school students can already get it if they want it. And
right.
And then comparing, we had in our county, we had a sheriff running for office. This was before Colorado legalized marijuana, but he was running for office, and a big part of his platform was marijuana is less of a problem than alcohol. And he wrote all sorts of really good essays talking. He'd been in law enforcement for 30 years, and he was talking about how in those 30 years he'd had, couldn't even count the number of times that he'd gone to a domestic violence call and been attacked by the perpetrator, or had someone driving the wrong way 100 miles an hour on the interstate, stuff like that. And he said it was always alcohol. It was never marijuana. Right. He never got attacked by someone who was high. It was always alcohol. And so he was trying to really call attention to the fact that we, with alcohol, we regulate it, we tax it, there's treatment facilities certainly, but people don't get locked up for if they are an alcoholic, they don't get locked up, they get treatment.
Right. That's a great point.
So that was, and then, I can't remember if it's been 2 or 3 years, but Colorado has definitely not seen any of the sort of fear stories materialize. In fact, I think the most recent thing I saw was that the tax revenue last year was just huge, because there is a pretty significant tax built into the price when you go to the shops and buy it. And so, I think it's been good for Colorado's economy, and there definitely we have not turned into a state of crime. And I know there were lawsuits brought against Colorado, I think by Nebraska and Oklahoma or Kansas, some of our neighboring states, and it just got thrown out of court. Those states were saying that because Colorado had legalized marijuana, they were having to step up their patrols because everybody was driving over the border, buying it and bringing it back. And, I think the judge, the case did get thrown out. So, in terms of other states might think that the crime rate has gone up, but that's because they see something as a crime that Colorado no longer does.
So, interesting, again, it's a substance that affects different people differently, obviously has some impact on the healthcare system, and Colorado's choosing to treat it differently fundamentally than others from a treatment perspective. And, David, interested in your perspective as an attorney, what's that going to do to requirements for healthcare delivery systems, healthcare regulators, et cetera, to require treatment for marijuana-associated addiction issues, et cetera? Because it's not criminalized, but people are still going to have issues potentially with overuse. Do you see that becoming a factor?
Right. I think one of the key factors there is education of clinicians, because I think some folks may feel that they're sort of thrown into the midst of an issue that they don't necessarily have the tools to deal with. I've heard radio interviews with emergency room physicians in Colorado who have dealt with the cases of, the local person who had a pot brownie or cookie and saw no effect, and then had another one, then had another one, had another one. And when it all hits, that can be bad news.
Ingestibles has been, I forgot to mention that, there has been some stuff with the edibles.
Right, and that's sort of a thing that has been problematic. And in Massachusetts, there's regulation of medical marijuana. There's likely to be a ballot question on full legalization at some point. But again, the edibles are an issue. They're not supposed to look like commercially available candies, et cetera. It's not, try to keep them out of the hands of kids and so forth. So there are a lot of sort of subsidiary issues that come up when you make one change. As in every case, there's always the law of unintended consequences, and we can't necessarily anticipate what all of those are going to be.
Great.
Well, we advertised this inaugural conversation, this inaugural blab, as a half-hour exercise. And what I'd like to do at this point is share a link to our next edition, which will be Tuesday, April 12th at 1 p.m. Eastern. And those of you who are viewing this live or maybe viewing this at some point in the future, can click on that link and subscribe, can show up on the 12th and join us. And we hope to have this continue to be a lively and open conversation about health wonky kinds of things. We invite your feedback. We'd love to hear from all of you. Let us know what you'd like to see, what would make this a more interesting experience for you. And we hope to continue the conversation through this channel as well as many others.
Thanks very much for putting it on, David. Louise, great to see you.
You too. Great to see both of you. And thanks so much, David, for organizing all this.
My pleasure. Thank you all. Talk to you later.
All right. Bye-bye.